Hey, how's it going, everybody? Welcome to RefreshMiami. My name is Ryan Breslin, I'm the founder, and Peter Martinez is over here as the co-director. Everyone give Peter a round of applause as he's in charge of these events. And Josh, who is our third, Josh is out there he's the one who checked you all in. So, big round of applause to everyone who helped put this on tonight. And also, give a round of applause to the Museum of Science for letting us have this event here. Without them, we would all be out in the street, right in the parking lot, doing a flash meetup with bad AV and stuff like that. So, we've got a great panel tonight. We've got representatives from all different aspects of the healthcare tech industry, and hopefully you guys will think up some great questions for the last 15-20 minutes of Q&A. I also want to thank our sponsor for tonight, IronHack. So IronHack graciously sponsored tonight's event, and they are going to come, Ariel, I think, is going to come up and talk about IronHack. So, welcome, Ariel.
Hello, Refresh. How are we doing tonight? This is terrible UX, but there's my email. It's actually pretty bad. And our website is below the chairs. So we're doing very well tonight. So I wanted to spend 2 minutes to tell you a little bit about what IronHack is and some upcoming events that we have in the next couple of months. IronHack is a coding school that teaches web and mobile development. It's an immersive, full-time format, very immersive, 8 weeks in duration, both courses. Our students are learning from 8 a.m. in the morning till pretty much midnight, so it's a bunch of pretty sick people. Our philosophy is to do this on a very practical and hands-on learning. Our instructors hail from some of the best companies in South Florida and other parts of the world. We have instructors right now from Citrix, Yahoo, eBay, Spotify. Oh, sorry, let's be here.
Yeah, now you're in the shot.
Now I'm in the camera. Should have told me earlier. We actually started the company in Spain. So our first 2 cities were Madrid and Barcelona. And we're very excited, as of 3 weeks ago, to have launched in Miami. After the course, our students get support from us to get employment opportunities, and we also help employers to find great talent. Last year, we trained over 200 people in Spain, of which I'm very proud of to have placed 90% as software developers. Mind this is not in the context of Miami where we're seeing buildings pop up in brick or left and right. This is a country that has 57% youth unemployment, 5'7" under 30. So the fact that we're hitting 90% is that's probably the thing that I'm most proud of from the last 2 years. So anyway, if you're interested, we already have 1 cohort going underway right now. This has been the easiest pitch. We have a cohort opening up in March 16. If you're not, I totally get it. But we want to invite you to 2 events. We have one on February 17th, which is an open house. We'll be there at Pipeline Brickell, 1101 Brickell on the 8th floor, from 8 a.m. in the morning till 10 p.m. to answer any questions, meet the staff, meet the instructor, meet the students. So you get a feel for what we do. The second thing that I want to invite to people that are not even interested in our courses is our hack show. Our hack show is the demo day where our students present their projects to our community. So if you're generally interested in startups, technology, even if you're a partner firm, please do reach out to us, visit us at the hack show. My name is no longer on the screen, but my email is ariel@ironhack.com. We'd love to meet you all. Thank you.
So, we don't have many announcements today, but our next event I think is going to be on February 26th, right here. So you guys all know how to get here apparently. So it shouldn't be hard to find next month. So without further ado, I'm going to bring up the panelists. You guys want to come up? And I also want to thank Mike Cuesta from CareCloud who curated this panel. And no, I'm not. And it was his idea to put this together and came up with all these questions and stuff, but he apparently did not want to be moderator tonight, so. Anyway, so you guys want to come on up?
Where you sit, like anywhere?
Anyway, you can sit on the floor if you want. So, thank you guys for coming. There's something you want me to introduce. Why don't you go down the line that way?
Sure.
I don't mess anything up. Make sure your mic's on.
Yeah, just turn this green light. Hi there, nice to meet you, nice to meet everybody. My name is Juan Molina. I am a founding employee, founding team member of CareCloud. We're a venture-backed cloud computing company. We have built practice management software, electronic healthcare record software, and really the long-term strategy and the way that we built the company is to, in essence, be the Force.com of healthcare, to kind of encapsulate it. It's great to be here.
Hello, Refresh. It is great to be back. So I'm Michael Montgomery. I am the Associate General Counsel for Miami Children's Health System. We run the Children's Hospital in Miami, and we have about 11 different locations with urgent care centers and outpatient care centers around the 3 counties. And I've been a patent attorney since I got my engineering degree in the 80s. Which is more than some of you have been alive, so. But I do a lot of technology and a lot of deals, and I'm excited to be here.
Hey guys, I'm Justin Kent. Welcome. Thank you for coming out tonight. This is going to be a really interesting and insightful panel, I think. I'm the lead scientist at Modernizing Medicine. I've been there about 2.5 years. We're up in Boca at FAU. We're an electronic medical records company. We make iPad apps for doctors, more or less. We do about 100,000 patient encounters every day, so those are all discrete data points of structured information that then we can use to start figuring out what is effective for people and give that information back to the doctor at the point of care. I mainly work on the iPad app. I also help with the patent portfolio, and my background before that is in application development, iOS. I've done a bunch of apps for big brands, and it's nice to be here. Thank you. Thanks to Brian. Oh, everyone give Brian a round of applause. Did we do that yet? Just making sure.
So, this is going to be sort of free form, and then we'll go to Q&A and all this stuff. But if you guys have something you want to, like, that's been itching that you want to talk about, bring it up. And then, so this is basically a conversation. I have some questions that Mike and I collaborated on, but we can do it however you guys want, alright? So, I think one of the biggest issues that people are talking about right now in healthcare is waste, right? So, how do you guys see technology eliminating the waste? Like, we're talking about trillions of dollars of waste right now in the U.S. in healthcare. So, do you guys want to?
For us, we prefer the term efficiency. We're shooting for efficiency as a positive goal, rather than focusing on the negative. So, we are big believers in the lean startup, and so we have all of these things bubbling up. We don't really have conferences on waste and things like that, but we just we focus on providing premium care and providing an environment where world-class doctors can get together and do that. These guys are transforming the whole industry in terms of leveraging communication and bringing things together so that all this efficiency can happen automatically.
So,
I think the reason a lot of you guys are here in the audience is to try to figure out what can you do in this space possibly. Maybe you're trying to do a startup, maybe you're trying to get a job, and really that efficiency equation and the waste is a place where it's a big opportunity. It's something, if you can figure out a solution that helps make the system more efficient, that saves everyone money, that makes people money, and that's how you can fit into this big puzzle with all these different pieces.
Yeah, I was gonna say the same thing. I think it really, the waste to me equals the opportunity, right? And it's figuring out, how you can plug yourself into that ecosystem. Whether it's on the periphery of healthcare, building specific apps that fix certain problems, or kind of re-platforming or rebuilding some of the core tools or tool sets that are out there today. So I think there's tons of opportunity. I mean, if you look at healthcare today, it's the largest industry in the economy, right? So there's tons and tons of opportunity as we see it.
There's all kinds of ways
Example
to.
here. I got an example. I mean, wasn't any real example. So, sorry. Hello? Okay.
Hang on. It's a push button on
So,
the
let
side.
me maybe how it sounds. So,
It's technology.
there's a local company called Phillip. They were based out of Miami. I think they're down in Orlando. They're in Boston as well. An example of how their company solves waste through technology. Through large hospital chains, they tend to have their own individual budget. So if you have a hospital chain that has 3 or 4 hospitals, they will buy the same machine 3 or 4 times. Cohilo, which is a local company, will allow them to buy the machine once, maybe twice, and they provide the logistics to move those products or that machine around between hospitals when they're needed. And so it frees up a huge section of their budget and it reduces their waste. And these machines cost millions of dollars, so they're saving a lot of money and reducing their overall.
You know, and just to speak a little bit about Cohilo, that's where I met you, by the way, at the Launchpad. So, you know, the value prop is there, right? They just got funding, additional funding. They raised $9 million that they just announced. So it's working, right? You can actually see that they're driving inefficiency out and waste out of the healthcare system.
While we're talking about inefficiencies, I think there's a lot more sources of it than most people think, because some of the sources of inefficiencies is laws, regulations, things that you don't tend to think about in a technology room, but will affect your business and your app and your software. So you've got to think about all that.
That's interesting, because then you're talking about, there's different aspects or viewpoints on the whole pie, because the consumers only see one side. So they see what the inefficiencies that they encounter in a doctor-patient or hospital-patient interaction. But then on your end, you know, you're seeing the opposite edge, or you guys are seeing through inside the practices too. You know, so that means there's a lot more opportunities than we realize, than the average person realizes. You know? And so, cool. So, what was like the biggest barrier or hurdle you guys faced in building technology for healthcare, like regulatory or anything?
Yeah, there's a huge amount of regulation in this space, and you know, it kind of, for an entrepreneur that is coming to Refresh events, you know, you might have this great idea in the middle of the night, you want to make an app, you want to make a startup, and I don't want to be discouraging, but it would be hard to do that in the medical space, because just to get to the home base and swing the bat, there's so many rules as far as HIPAA, high tech, meaningful use, PQRS, CQM. I can hit you with like a million of the different rules you got to comply to. So to get an engineering team to get your innovative solution in the marketplace, you have to overcome all these other things first to even get to that feature you want to create. So I think that it takes being able to work with other companies, being able to find a constellation of solutions that fill in the pieces. You know, nobody's really working by themselves in this space. You have to work together to make it happen.
Yeah, all that alphabet soup is a little intimidating, but basically the fundamentals of it are the legislators and the regulators are very passionate about the privacy of medical data, very passionate about the integrity of medical decision making. They get really irate when somebody influences the decision of a doctor or a healthcare practitioner to select a particular product. So all of that alphabet soup is generally about protecting those things, and it's very well intentioned, but it adds a lot of opportunities for efficiency.
And it's kind of too bad, because you know that so much of this is towards protecting the patient, but then that same patient's going to turn around and post on Facebook what their diagnosis is and what their, you know, the girl I went to high school with is like live blogging her cancer treatment right now. So her doctor wouldn't be able to do that.
No, absolutely not.
All her providers, they have their hands tied in that respect. But the patients really don't necessarily, it can be a barrier, but as someone creating a solution in the space, you must comply. So it's tough.
So Mike, you guys don't have Twitter hooked up to your EKG machine anymore?
They're working on it.
Yeah.
We had a conversation about Twitter just today at work.
Of how much you guys can't use it.
There's a lot of room for efficiency in the social media space. Yeah.
Sure.
You know, another thing, it's not just regulations, it's sometimes, I feel a push and pull between the patients and the providers. Something that you want as a patient might not be with the doctor. Like, to us, we're all techie people. I want to be able to email my doctor, I want to be able to Skype my doctor. Most doctors don't really want that. They see it as liability. Yeah, all the things you do, and so I end up, you know, I work at a healthcare company and I'm like texting my friends who are doctors to try to get, you know, is this bad? Should I go in? And
Yes, you should go.
right. So
Sending pictures.
I think, yeah, that's something that we haven't really. I am texting pictures. You know, is this head wound? Do I need to go to the ER? Can I
I did that all the way here. Actually.
Yeah. So that's something that
They
I
still
don't.
talk to you?
Yeah. Sometimes.
Half the time.
But I don't think there's been enough work done in that particular place.
Yeah. Yeah, I mean, you have a lot of like doctor-patient barriers that need to be set in place because like, in your case, like most doctors don't want to be accessible 24 hours a day to their patients. And patients have a misinterpretation of what the relationship really is because they see the doctor as this is the guy who cures me. So anytime anything is wrong, they should be my like consigliere of health, you know, like they should be there to answer my questions because the average person knows so little about their own health, you know.
Right, so, but therein lies an opportunity,
Yeah.
right? So telemedicine is this big buzzword, right? I know that MCH is doing a lot of work there. You know, there's a company that just raised money as well, Teladoc, right? You go to their website, you log in, you know, you pay a subscription fee or per visit and boom, you've got a doctor live in front of you, right? Where you can show them that rash, right, that you're worried about, right? So there's a lot of opportunity, but still there's not a lot of adoption, right? So the question is why? And the question is, you know, is it the UI piece that's just messed up? Is it that you're not, you know, you don't know how to engage the patient correctly, or is it a marketing play? You know, so but there's a lot of opportunity I think that still exists just in that one space in this big, you know, gigantic thing we call healthcare IT.
I think you mentioned the user experience, which is a key point because the customer or the consumer doesn't know why, for example, they should be paying for the chat window that popped up, right? Because they go to a website for an insurance company and there's a free window where a person will chat with them. And we have to educate them on the difference between that and this is a doctor who's got malpractice insurance. And they're standing there and they're not taking another scheduled appointment for this chat. So it's more, the whole messaging is off. We have to do education in all directions, up, down, and sideways. You know, the technology guys, they just want to build a cool app. They've got an idea and they want to test it out. Well, that testing, there's a lot of stuff that has to go around in the back end because the doctor wants to know that they're covered from an insurance perspective. The website has to have insurance. They all have to talk to each other. What happens if the chat is from a person that's not in the U.S.? What if there are U.S. citizens that's traveling in the Caribbean islands? What if they're having a heart attack and they need to be medevaced? Right? Your telemedicine app needs to think about that kind of stuff. Okay? Sorry, did I bring the room down?
No. So we're talking about like how the user sort of like what their expectations are based on the interface, right? Do you think if they saw a person in a white coat, they would think, oh, this is a doctor, versus you know, a tech support guy in India, you know, like, and then they would mentally associate with the, you know, this is someone whose time is much more costly or valuable than the tech support guy that you call for Dell. You know.
There's a whole lot of psychology around that white coat.
Yeah, and that's a good question. You know, telemedicine is still very much in its infancy. It's heating up a lot right now. But it's not just telemedicine, it's a whole UX thing where if I need some help and I dial you up in my app and you look at the bump in my arm and say, oh yeah, that looks serious, you need to go check that out, that'll be $50. I'm sorry, that's not good UX, and that's gonna happen a lot of times. You know,
Yes.
telemedicine can't solve everything, so in some ways it could be a false promise if we don't really deliver.
Or educating the consumer, right? And we're setting the right expectation, I think, is the other thing that will really drive that.
Having said that, it's absolutely necessary, because try getting a doctor's appointment. You know, you're talking 5-6 weeks wait time. It's either gonna resolve or you're gonna end up in the hospital.
We've had good experience with the sort of video receptionist concept, who kind of triages the calls and you know, because some calls are pranks, right? You gotta deal with that, you gotta think about that. Some calls can go to the on-call nurse or whatever. Some calls need to go to, you know, maybe they're paid for a specialist or a subspecialist. So all of this stuff, look, Lean Startup applies to healthcare because we've done it. We've built enormous software technology solutions that 200 residents took one look at and decided that it took 2 minutes longer than the paper they were using and never used it again. So I'm a fan of the Lean Startup, you know, pursue or pivot.
Right. I think the challenge though is how do you build an MVP that falls under all the regulations? You know, like, sure, we could have built a form that, you know, lets them dump all the data in instantly, but if it's not meeting all the criteria of the alphabet soup as you put it, you know.
Yeah, two concepts for that. One is dummy data, and the other is a good lawyer to write you a beta tester agreement.
Okay.
It's not insurmountable, right?
Right.
It can get done. It's really just understanding what that regulation is, how you play in that space. You know, understanding what HIPAA is and what PHI is all about. So, you know, patient health information, and CQMs, and what that's all about. But it's you can learn it, right? And it's just a matter of, I think that the advice is sage. It's getting a good attorney to make sure that you're protected, and you can do all sorts of stuff with dummy data, right?
I want to go back real quick to the point Michael made about the paper and the EMR taking an extra 2 minutes and people don't use it because, you know, there you go. It's a very powerful medium, and we as technologists, we're kind of in love with the technology. I want to make an app because I like using my iPhone. And that's not necessarily going to be good enough in the medical space because everyone's on paper. Yes, they have to move to digital now because of the High-Tech Act and meaningful use, but to have a pen and paper is really so flexible and so fast, and you can do so much with it that to program that into your interface, you just can't program. Imagine if someone comes in and you have a checkbox and it's male or female. And there's a lot of situations where maybe those two checkboxes don't completely apply. Well, on a piece of paper, you don't have to check a box. You could write an arrow and you can make a comment and you could say, see me later and all these things. But to program that type of logic into your EMR is like, takes a lot of additional man hours from just that two check boxes. So that the bar you have to get over is not just all this legislation, it's also, you need something that's drastically better than paper, it's drastically better than what people have used in the past, or they're not going to adopt it, they're going to rebel against it, they're going to undermine it, and your solution won't get the traction it needs to succeed.
Yeah, okay. I was going to say, I mean, I totally agree. So in our industry, right, there's this whole big buzzword known as meaningful use, right? You probably have heard about it. The stimulus of the High-Tech Act, right, incentivize physicians to go out or providers to go out and adopt technology, right? But think about how backwards that is. It depends who you are, right? If you're a healthcare IT company, it's great because it drives adoption, right? But if you're in the industry, you're a provider, you know, I'm not sure how good that really did for the industry, because if you think about it, you know, when you let government dictate innovation, I think that's a problem, right? When they tell you you've got to build this stuff, it's a challenge, right? But, you know, the reality is that meaningful use has probably not done the good that it was supposed to do, right? So when you go out and you build an EHR, so for example, we've got huge adoption numbers. I know Modernizing Medicine has huge adoption numbers because you crack the code on the UI, right? And when you crack the code on that UI, the UX piece, you can really win. And there's this whole, you know, class of physicians that have gone out and adopted EHR, right? They went out and they said, okay, I'm going to go get this technology, but they adopted it and then they realized after, because they had this carrot of, you know, money in front of them to go adopt EHR, and they realized this really slows me down, right? And now the analysts and everybody loves to talk about this rip and replace market, right? The challenge is that people aren't ripping and replacing because they're not going to go from one crappy piece of software to another crappy piece of software, right? They're waiting for that promise, I think, to be delivered, you know, on a much better user experience. And I think, again, that's a huge opportunity. Your residents, I think, you know, was a perfect example of that.
Yeah, you know, UX goes two ways. It goes to the user, the end user, and it also goes to a professional. But you bring up a good point, because well-intentioned regulation is still regulation, right? On the UX piece, you know, it may be as simple as, why can't I just hit one button and have the same thing that I just did 2 seconds ago, and then I can just fix the 2 pieces of data that I need to change rather than filling out all the form fields. That never occurred to that engineer, but it was the one thing that stopped the whole thing from working. And now, once they've been burned, they won't try it again. So, again, you know, MVP Lean Startup, work with the person to have the beta tester on the dummy data to understand that UX experience and iterate. Yeah, exactly.
I'm curious, I know we're throwing out a lot of terms. How many people are familiar, how many of you know what is meaningful use? Just raise your hand real quick.
So like 5%.
Okay, and then I guess PQRS is going to be even lower. So what meaningful use is, there's this thing called attestation. So doctors who are using medical practices that are on paper are having to switch to electronic medical records. And the way that they can prove that is through this meaningful use attestation process, and it's phased in over time. So you can't just buy an EMR in EHR and just not use it. You have to actually use it, and there's all these requirements. You have to, for instance, do a certain percentage of e-prescribing rather than physical, write a script and hand it to the patient. Now, the PQRS is a step beyond that, and it's basically grading the doctor on the quality of care they're providing. So, for instance, are you overweight? Do you have diabetes? Are you a smoker? Well, if so, I should counsel you on those things and tell you maybe you need to look at your diet or your exercise or ways to reduce your smoking, things like that. So these concepts are very important because over time, every year they're increasing and increasing and increasing, and they're tied to your Medicare reimbursements. So if you don't fulfill these things, if you're not a certified software solution for these things, really no one's going to buy your software because they're not going to be able to get their Medicare reimbursements, and those percentages over time are increasing. So some of this is good because it's like the carrot and the stick, but I see it some way also as demotivating certain people, because in the past, if you had a doctor that really cared about you as a patient, they want to make sure that you're healthy overall. Not just, oh, let me fix your problem and send you home, but they want to spend some additional time with you. They want to talk to you and figure out you as a person and help you. Now, in a way, that's kind of been reduced to a couple checkboxes. It's like, okay, I asked them this question, I counseled them on this, I'm done, now I can get my reimbursement. So in a way, it's like a little bit of a reverse incentive. But this is just the way things are going. And there was a big announcement 2 days ago, actually, that now all of this stuff is moving less for pay for treatment and more towards quality of care. So this is something that's been happening in Europe for a long time, but you're really your reimbursement will be tied more and more to, are your patients getting better or not? And how do we grade the providers on that? So right now, most DMRs aren't even close on that. There's really no way for them to do that, but it's going to have to happen. So that's a place if you can either make a doctor or an MA or a nurse more effective and help them with their outcomes, or if you have a way of measuring a patient, are they doing better or worse, there's going to be a lot of movement in that space.
While we're talking about some of the alphabet soup, most of the regulations we're talking about are US specific, and they're federal regulations. When we talk about an EMR or an EHR, that's an electronic medical record, when you talk about the checkbox, that really strikes a chord with me, because one of the things we had to deal with when we transitioned to an EMR was the phenomenon of the doctor looking at the screen saying,
Right.
no, the patient's over there.
Right, the screen's over
Right,
here.
the screen's over here. So, I see you gained a little weight and you exercising. It was horrible. So, the whole the whole technology didn't work. But when it works, it's awesome. My daughter had to get an MRI and a couple x-rays, and seeing those on the 27-inch double screens, and you could see them in 3D, and the mouse would move them in and out and scroll, and you know, the days of the old x-ray film, and there was 12 of them. Seeing that on live video with you could see it through the knee and point to things. When it works, it works. It really works. And that's what we're all here for.
Yeah, that's a really good point, the doctor-patient connection. And our product it's on the web, so you can just, any computer, laptop, desktop, doesn't matter, but we're also on the iPad. And 85% of our providers use the iPad over the web, and I believe part of the reason is, if I'm seeing my patient, I got my iPad right, I'm face to face with you, I'm not turning my back to go type into this computer. It does matter.
It does matter. It absolutely matters. And you can take a cart or a kiosk and drop it in the middle of nowhere, and you can have the number of opportunities is astounding. For example, just the little thing like a video call. The number of people, the percentage of this audience that can do a video app, right, is probably pretty high. But can you do a video app with low latency to anywhere in the world that has enough resolution for an X-ray, right, and yet is so secure that it's HIPAA compliant? Not many can.
I think I heard a yes.
Awesome, let me talk to you.
His phone also does x-rays too, so.
I'll say that.
It's called MD Live.
Yep.
In Sunrise, Florida. It does all of that.
Excellent. You're in good company.
So, alright, so one of the big topics nowadays is also patient-generated data through different like devices and apps and all that stuff. So things like Fitbits, Apple Watch coming out, you know, all these things. Where do you see that going as far as like user adoption or doctor adoption, or, you know, I mean, I don't think my doctor's ever asked me to see my Fitbit data.
Yeah,
He would be impressed, but.
But you look good wearing it.
Yeah, thanks.
Yeah, so you know, I think the first place you start when you're looking at opportunities there is obviously, not to use the big word, right, the cloud, right? But you know, all this data, it's very difficult. It's possible, right? Technically possible, but it's difficult to have that data. That data should reside within the electronic medical record, right? So at the time of care, it presents to the physician. So as I see you've been running 10 miles a week, etc. Right? It's very tough to do that under Betty's desk in some client service system in some office somewhere. So I think that's where you start, right? You know, I like what Apple's done, where it's all, you know, the patient opts in, they can push that data, etc. You know, kind of anecdotally, Mike and I were just talking. I was in Cupertino about a month and a half ago, and you know, what's interesting there is that, you know, nobody obviously is wearing the Apple Watch yet, right? But we met with their healthcare team, and every single person in the healthcare team was wearing an Apple Watch, right? Which is pretty telling, because I asked them for one. I was like, hey, can I have one of those? You know, obviously they just ignored the question. But what was interesting is that you walk around the campus and nobody's wearing it, but yet, you know, like I said, everybody on the healthcare team is wearing one. So I do think there's going to be something there, right? The question is, you know, what? And again, I believe there will be opportunity within just that niche to build apps specifically for that are health related.
But you don't think in April, once they ship them, that every single Apple employee will be wearing an Apple Watch?
Well, yeah, probably.
You know, and Cook will be looking at everybody's health data 24/7.
Yeah, probably.
You know.
Well, how about health data that the patient can correct? Talk to me about the doctor who's being asked to rely on that data that can be corrected by the patient.
Right. Right, or that they can cheat on. They could attach the Fitbit to their dog's collar and let the dog run around chasing the ball. You know, all of a sudden they did 15,000 steps in like 5 minutes.
Right, or the teenage diabetic that changes the calibration on their meter so the numbers look better.
Right, so their insurance premium goes down, right? Yet the doctor's medical license is the one that's at risk there, right? So, you know, lots of, again, opportunity.
Well, the insurance companies are doing pilots now, like wide-scale pilots with these health trackers and stuff. I've heard in the Midwest, like they're giving out 50,000 of these things to their patients.
Right, most of it's incentive payments.
Right, right, like, or they'll give them free gym memberships or gift
Back to your
cards.
check boxes.
Yeah,
Right.
yeah.
Well, there's places you can make incremental change, and then there's places you can have this revolutionary, whole new world type of change. And I believe we're doing the best we can in modernizing medicine on the provider side, and there's some really cool stuff we're doing. We're working with IBM Watson, we're doing a bunch of data stuff, but I see that Fitbit, Apple Watch type of patient-generated data, that will be a revolution because it's data we just don't have now. If you're dealing with something, recurring skin issue, if you're dealing with a vision issue, you might see your doctor once a month, every few weeks, and they get a data point once a month or every few weeks, and that's just not enough to know if the treatment is really working the way it should be. And if you can start getting information every day or multiple times a day, wow, there's so much that you can do with it that's really the next step. It just makes me excited as a patient.
I mean, if you look at some of the opportunities again, that exist not only just on the patient-created data, right? It's what about the data that's created biologically, right, out of your own body? So if you look at genetics, and you look at, now it costs $1,000 to map your genome, right? What if you can then tailor medicine, right? So again, additional or incredible opportunities that we'll probably see the likes of the Mayo Clinic, MCH, right? The Cleveland Clinic, and all of these places really creating tailored medicine based on that patient's genome. Again, huge opportunity there on, are you the deliverer of that message? Are you the repository of that message or the registry of of that gene and so forth?
One of the exciting projects that you reminded me of is called Tide Pool, and they're taking the data generated, in this case it's diabetes data, and again, they might see their endocrinologist every 3 months, but they may have a continuous glucose meter that's producing data every 5 minutes. Well, this Tide Pool group is doing an open source interoperable with all the devices in Mac and Windows. And they're putting together all the code, and it's all on GitHub. They're doing an uploader from every single device. And they're doing awesome data visualization kinds of things where you can combine things, where you can do it in the cloud, and you can have, for example, parents who can monitor their student while they're in school. And so there are lots of opportunities, and people are doing exciting things. That's why we're here.
Yeah, and if you look at it from a startup perspective, right? If you look at what happened last year from a funding perspective versus just 2014, right? Last year, the total funding in digital health was about $6.5 billion, where in 2010 it was $1 billion and change. Every quarter in 2014 represented more funding than the entire year in 2010. So the market is definitely heating up, right? There's incredible amounts of opportunity in the startup world.
So when you guys mentioned a key word that I think we should expand on, which is interoperability. So how big of an issue is that? You guys see different EMRs talking to each other?
Yes.
If you think about it from a business standpoint, if you're an EMR provider, you don't want anyone. You want to trap your customers in, right? You don't want them to.
In theory, right?
In theory.
In old school,
Right.
That's the old school thinking,
Sure.
right? Yeah, go ahead.
So what's the new school? What's the future of that?
How do we do that right?
Yeah, well, your interoperability is now required.
Okay.
So you have to be able to communicate back and forth. Portable patient records is the term, and there's a protocol. It's a very old, outdated protocol. It's called HL7.
I was hoping you were going to say FTP.
No, they communicate over it. They communicate that way, yeah.
Yeah, so I need to be able to say, okay, here's your patient record digitally. I need to be able to send it to your other provider. They need to be able to take it in. The challenge is HL7 is there's just enough interoperability. You hear that as an engineer and you think, great, there's an API I can hit. This is going to be easy. It's just an integration thing. But the data is not really, so everybody's got their own flavor of HL7. The way you store things in fields, a lot of that was left up to individual decisions. So it's a big challenge being interoperable with everyone because not everyone's stuff is the same. And that doesn't even get into what if the data's bad? What if someone put the wrong number in a different field than they should have? So there's whole companies that only do that. There's this company, Mirth, that
Right.
they sell product that kind of helps you be interoperable. And,
It's open source biz stuff, right? Pretty much, for lack of a better term. I don't know where to begin.
So, I mean, when you think, like, a patient will be able to tell their doctor, hey, I want my records on my phone, you know, or like to download them.
Yeah, so we talked about, go ahead.
With one provider or all of them?
Anything, like, I wanna walk into my orthopedist and
Different
say, I
problem.
want my, you know, knee x-rays and everything in your summary, and then I wanna go to my, you know, endocrine guy and say, give me my records, and I wanna have it all centralized on my device.
yeah, and in theory, you should be able to do that right now. If they take Medicare and they want to get paid, you should be able to
Yeah.
log in and do that, but
But on the consumer side, there's no way for me to,
right, who's actually
Process
doing
that,
that,
yeah.
how you download it, and that's a big problem, because I really believe that data should live with me as a
Right.
patient. I should own that data, I should have control over that data, I should have access to all that data. And right now, if your doctor uses a particular EHR and then a year from now they decide to switch, a year from now they go out of business, that data's gone.
wasn't that what Google Health was trying to do, giving everyone their own, like, lockbox of EMRs?
Yeah, Microsoft Health Services also.
Yeah.
I think
And
those guys are
everybody-
struggling with the
yeah.
business model of it because nobody wants to pay individually.
It's also a challenge for the doctor to trust the data because their license is on the line. They're trusting every company that's producing the data.
Right. I mean, that seems to be a recurring theme, like if the data can be modified by anyone, or the data integrity issue is a big one, how do you resolve that in the long run with, you know,
It
with
is
so
an
many
issue.
sources?
You know, it's scary for a doctor who's got the CYA and there's the legal things, but I personally, that doesn't scare me so much because you're only cheating against yourself. Yes, maybe something to do with your insurance rates, but there's such a huge upside for people who are, I remember there's this part in the Steve Jobs biography where he's battling his cancer and they've got a whole team of doctors, the best doctors money can buy, and they weren't really communicating together and they were doing these big meetings where they try to get them all on the same page and they're sequencing his DNA and they're trying to figure it out, and he's saying, either I'm gonna make it to the other side of this or I'm gonna be one of the last ones to die from this because we just haven't figured, we're not quite there yet. And that is a very real upside, and so I'm just so much more optimistic about that than I am worried about someone, you know, working the numbers because last month I told you I was a smoker, then I realized my insurance went up, so I want to go back and change it. And in our software, you do have the ability as a patient to go in and change that, but it doesn't actually change the record. It's all audited, and next time the doctor comes in and looks at your chart, they're going to see a alert. Justin changed its value, do you accept it or deny it? So it's all kind of approved or denied by the doctor.
So they've thought about it.
So, I guess one of the other things, you said you guys are working on like Watson stuff, so that means you're talking about big data aggregation, data processing. And so, do you think that's gonna be a bigger, like, utility for the insurance providers and like the Medicares of the world and stuff like that to improve patient care by doing, you know, being able to better consume and process trillions of, you know, petabytes worth of data?
Yeah, for sure, it's them.
Yeah.
It's also the clinical trials, because those are extremely expensive, and if you can just have all these people, just get the data that's just happening, that saves you a lot of money. It's also the pharmaceuticals. They want to know how well their drug is working and for what it's being used. So the data is very valuable.
And for providers too, right? So, you know, what are, I think
Yeah.
a feature that you guys have that I think is brilliant is, you know, what are other people in my specialty across the country currently prescribing for this, you know, condition, right? So, you know, having that instant access, all that data aggregated, and again, at the point of care, is interesting. You know, I'm not sure if that's right or wrong. I'm not a clinician, right? But it's interesting to be able to present that, and I think there's tons of opportunity on the analytics side in healthcare as well.
I mean, that could be a fascinating opportunity for you to be able to see, like, everyone's prescribing ibuprofen for this, and it's actually not working, or it is working, because you can see
Yeah.
follow-up data
Yeah.
from those as a whole and an aggregate.
Right, and some of the drugs now that are coming out, the biologicals, they're so expensive, and the FDA tells you it's something safe and it's something effective. So when you prescribe, you know it's safe and it's effective, but you don't really know how effective it is. Nobody knows that information right now. So if I'm making the decision between prescribing you something that costs $1 per pill and $80 per pill, and this $80 pill is only 5% more effective, it might not be worth it. There's two ways we're approaching this problem right now. I'm sure there's a lot more ways to approach it, but the way we're doing it is like you mentioned, looking at our data. We're getting millions of data points a month, practically a week. And what can we tease out of that to see, start with what's more popular, then go to what's popular for what have I prescribed in the past, what have other doctors in my practices prescribed, and what's happened nationwide. Then you can go from there to what is more effective, what is actually working over time. But that's just data that we have, and try to statistically figure out things from that data. The other kind of opposite approach is the IBM Watson approach, where we're looking at medical journals. So we're looking at the research and we're looking at peer-reviewed information and just putting it all into Watson and then asking natural language queries, hey, with this type of patient, what should I do this or should I not do this? And Watson will kind of tell you, okay, with a 99% accuracy, I believe this is the answer. So there's two ways that we're using big data, but hey, there's going to be a lot more in the future that we figure out.
So I am a lawyer, and I have to usually tell people that this is not legal advice, but everything we've been talking about tonight, as soon as you start talking about FDA approvals and human clinical research, it all gets exponentially more important and more challenging. So.
I mean, one way that HIPAA helps in this regard, a lot of people see HIPAA as a big obstacle. I just had a conversation earlier tonight about that, because it does get in the way sometimes, but HIPAA has given us guidelines of what fields in your record are PHI, private health information. What can you share and what can you not share? So if the government tells us these are the things, name, date of birth, age, social security, those things, if we can't share those, well, it then becomes not too hard to de-identify that data and just scrub that data and replace it with other things. So then we have all this rich information. I can't track it back to a single patient, but I know that, legally I'm safe when I'm using that data.
So I think the last question I have for you guys is, what do you think are the key opportunities specific to South Florida in this space?
Yeah, so if you look at South Florida as a whole, right, it's an incredible healthcare market, right? 5% of all U.S. healthcare, the last statistic that I saw is 5% of all U.S. healthcare is, 2% is a 50-mile radius around Miami, right? So lots and lots of healthcare just in South Florida itself. So there's an incredible amount of opportunity there. I mentioned earlier when we first started the discussion that building something on the periphery of healthcare, right, and then building entry points, exposing your API and saying, okay, hey, antiquated healthcare IT vendor, I've got an app that does this, that fills a specific gap that you don't have in your product. For example, we're talking about pay-for-performance now, so doctors are going to be incentivized on how the outcome is. Right? And because of that, insurance companies are going to now require authorizations and require different things from the providers. Building everybody can do an e-prescribing app, right? Submitting a prescription electronically, but what about doing e-pre-authorization, right? An app that does that, something niche to then plug into these, large monolithic, healthcare IT systems, or, building companies just to do that. It's just one example.
For patient population, I think South Florida, the biggest healthcare opportunities are in geriatrics and pediatrics and also medical tourism, because we've got a fair number of folks coming to Miami specifically for medical treatment. In terms of technology, gosh, it's just astounding how many opportunities. Just simple things like inventory management, consignment, prescription management, just portability of records. There's a reason that these guys now outnumber me 2-to-1, right? The data, the opportunities for technology and development is really exciting because there's lots of opportunities for efficiency. Just even remembering, you used to have a thing called a pillbox with a container for every day. If you could do that in a way that was smart, that would be awesome. So this whole group is about bubbling up that idea, those ideas.
Yeah, I agree. I put it back on the people in this room. There's a lot of really great medical innovation and new stuff happening that's helping. And then there's a lot of medically underserved people in this community that don't have access to any of that. And what we're doing at Modernizing Medicine, this is an awesome opportunity for you guys. We're planning a hackathon in the last weekend in March, and it's devoted to helping helping improve care for medically underserved people in Palm Beach County. So we're up in Boca, and we partner with the Quantum Foundation and FAU Technology Runway to do this hackathon, where we're having 6 area nonprofits, great causes, and they're going to bring their, like, a day in the life, some of the problems they face, and we're going to, then you have 24 hours to form a team and come up with solutions, a little bit of innovation, a little bit of technology, and we're giving away $10,000 in cash, but we're also giving away $100,000, well, I shouldn't say that, we're giving away a lot of in-kind application development time so that your idea, the best idea, will actually get made, productized, and put to use in Palm Beach County, helping people that need that help. So it's an awesome opportunity if you want to get started in this space and build up your resume, or show that you've had a success, or show that you've just helped somebody, improve somebody's quality of care in their life. I have a bunch of flyers, so afterwards I'd love to hand each of you a flyer and check it out. We have an awesome website started, and it's free to enter, so it's the last weekend in March. It's called Code for Good.
Cool. So I think that was the last of my question, so I think I'm going to turn it over to the audience. We have about 5 to 10 minutes left. So if you want to ask questions, stand up and either come up to one of the mics,
We have a couple of mics.
or just talk really loud. All right, in the middle.
Hi. I know that you've alluded to this a couple times, Justin and Juan, and it might be less applicable to Miami Children's, but CMS announced earlier this week about transitioning 50% of payments to value-based payments as opposed to fee-for-service for Medicare patients. This is big news. I'm wondering how your organizations are thinking about this and how they're approaching either incorporating that regulation into your strategy or just helping physicians that need to.
So it's a great question. It's something we've been anticipating, right? And there are companies already that are doing this. MSOs that are out there that are that's how they get paid today, Medicare Advantage plans, etc. So the way that I think that the way that we're looking at it is a data aggregation play, right? And it's pop health, and really kind of again pushing at the point of care, the information that provider needs in order to ensure that either they hit what's the word that I'm looking for, I'm trying to think of the word, it's basically all the protocols that they need in order to ensure that they're providing great care for that patient. But then alerting the patient back. Sorry. No, I can't, it'll come to me. But then alerting the patient back, or alerting the provider back when they're being hospitalized, right? Or when they're going to another physician's office. So a lot of data aggregation and really playing nice and playing well in the sandbox with other constituents in the healthcare continuum, whether it be the payers or the providers or the hospitals, right? So I think you'll see the advent of more interoperability, as that becomes more real.
You're obviously well informed, and it's a great question, and we actually love it because we've been pushing this direction for the past 4 years, and it's great news for us because so many people now, the providers are like, oh my God, what does this mean? It's exactly your question. What does this mean for us? And we're able to say, use our solution. It does everything you need. So, we already support ICD-10. Yes, it got pushed back a year, but we're ready to go with that stuff. We have a great system for PQRS. We have all these, by using all these new rules absolutely require structured data. If you don't have structured data, how do you know whether they're getting better or worse? And we've built our whole business and our whole product on that idea. So it just kind of justifies what we've been doing, and we're completely ready for it. So we can tell anybody out there who's wondering, hey, we got your back.
Cool. So, next question? Again.
There's one in the back. Oh,
I need the microphone. I'm only loud spoken when I'm Cuban, and then I get mad, and then I'm loud spoken. I just wanted a show of hands. How many people here are caregivers to elderly parents? Just one? Two? I was the lights. Okay. I have been a caregiver to my parents for 7 years. My mom passed away in August. And my dad is still alive, but he lives with me, and we're under hospice care at home. And through this entire process, taking them to many doctor's appointments, and basically becoming a patient advocate, I could probably get my own CNA license at this point. I have thought of many ways that technology could work. Now, getting back to what you guys were discussing earlier, with Vita's Hospice Innovative Care, we are old school. If something goes wrong, you call them on the phone, and within 2 hours they have a nurse at your house. But wouldn't it be cool if I could somehow beam my dad or something and take his blood pressure without having to do the pumpy thing, although I know how to do that, so that they can monitor his stuff from the home. There's other issues too, that when you get into geriatric healthcare, sometimes your parents are semi-independent, and some people install cameras that you can actually see what they're doing on your iPhone. And that's going to be really important, because otherwise you have to have someone there with them all the time. So it's like a baby monitor. So these things become really, really important with elder healthcare. I wish that there was a way that was seamless, that the cardiologist, the neurologist, the gastroenterologist, and everyone was on the same page. Because I used to create Excel spreadsheets on the medications. My dad has arrhythmia, and I have to take him to the lab every other day for a PT test. And so okay, now it's 5 micrograms less, 10 here, and then order it from CVS. It's a pain in the ass, So I wish it was seamless, because nobody cares about the caregiver. These apps and this technology has to be good for the caregiver. Every single person in this room is going to be a caregiver at some point. You're going to be a parent to your parents. So I call it the 60-year gestation period. Even if you don't have kids, and by the way, I was so loving on that baby over there, because it's so nice to have baby energy. And I'm telling you something, you haven't lived until you've changed an adult diaper. And now I do it like this. But it's different because it's a 140-pound body. And you have to learn these things. We have to be patient advocates for ourselves and for our parents and the people we love in our lives. And you can become a caregiver at any point in your life. Your spouse might get sick. It doesn't have to be an old person. But eventually, if you love your parents, you're going to have to take care of them. And what I would love to see, and I want to talk to you after this, is technology that is, because the baby boomers are only getting older and they're not getting better. They're taking stupid pills like Namenda that don't really help. I mean, pharmacology is really crazy. It doesn't really help. And nutrition, and we need to talk about these things that make people better.
so we were talking earlier, just in this room, it's going to sound like a funny question, right? And so she's caring for her dad, and it's a daily... And it's a daily struggle, and one of the things that she just interrupted the conversation herself with is, why can't they send me a text? Who? These people, right? So she's paying for a service, and they won't text her. Probably because of a lot of the opportunities for efficiency that we're talking about, but just little things that can just transform a person's life. So there's a lot of excitement.
And again, I'll use the word that I've been using over and over again, lots of opportunity, right? If you look at, for example, the healthcare system as a whole, these systems were built pre-Star Wars, right? I mean, they're old. They're really old. As a former tech ops guy, right? You know, if you look at the architecture, you look under the hood, I mean, you want to throw up, right? So there's tons of opportunity in really disrupting just, you know, all of these different technologies out there.
I mean, first of all, I just want to say sorry for your loss, and I can really see what a hard struggle it has been for you. And, you know, I admire what you're doing. I feel like the term you use, patient advocate, it really lies there. You know, we're at a time where we can really be empowered patients and empowered advocates, and a lot of people see medicine as, I'm sick, I showed up, fix me now. And a lot of times that's really too late, and we need to start taking control of our own health information and our own lives and what we do and what we put in our body. And that's more possible now than ever. And I really hope that you'll be able to participate in the hackathon, because that's the exact type of solutions that we're trying to create, because we can't wait for some wonderful provider in the sky or the local hospital to create that for us. If we wait, it'll be too late by then. We have to create these solutions ourselves. And now we can, because that phone in your pocket is enough to pull off what you need probably with the right app.
It's funny you mentioned we're not waiting, because there's a hashtag, we are not waiting, and it's being used by people who have diabetes and are hacking their own medical devices to put their own diabetes data on the cloud. It's already being done, and they're all patient advocates.